I'm here with Hannah Lollar and Megan Konopacke, and we are going to be discussing eating disorder treatment today. Hannah is a specialist that is a therapist working with those with eating disorders, and Megan is a family nurse practitioner that has been working with eating disorder patients at a residential facility in Logan. But I want to ask Hannah both of you, how you guys got into this specialty. Where did the passion come from to work with people with eating disorders? Because you both know that it's not easy.
Definitely.
Yeah.
For me, I've always been interested in them. Like, I remember being a teenager and thinking this is what I wanted to do. And when I was even an undergraduate, like, I did final projects on eating disorders. Just kind of fascinated by the complexity of them.
Mm-hmm.
And I think that there aren't enough providers and it's really hard to get care. And so if I can add myself to that field and make it a little easier for some people, it'll be beneficial.
Yeah, definitely.
Yeah, and kind of I would be around a lot of people that have had eating disorders when I was growing up. So like I had like a best friend in college that I could actively see her suffering from it, like family members. And so I would see it, but that never really like triggered like that's what I want to do with my life kind of a thing. Like as a nurse, I worked in like an ICU and then I went into family practice, and I never once like during school, because it's not even taught during school for practitioners anything about eating disorders really. But then when like going through clinicals, like I loved like working with like the mental health aspect of things, but I still wanted the medical component, and I felt like eating disorders were like a good mix of that.
Yeah.
And then once I started, I realized there's so much to do with it, and like you said, there's literally nobody out there, so definitely a gap in the market.
Yes, it's very hard to find care. And you are not from Utah, Megan, so did you just find the job and then head out to Utah? Did you like to ski?
Yeah. Yeah. So I would come out to Utah anyway just to go skiing every year. So when I was like trying to figure out where do I want to go after I finished like college, I was looking around jobs in Utah. Then I saw an eating disorder treatment facility. I was like looking into it and it looked super cool. And I was like, well, I guess I'll give it a shot. Like I have no experience, so like there's probably not going to be anything, or I don't even know if I would like it. But then it ended up being like such a great decision. And now I don't know what else I would be doing, honestly.
Yeah. Yeah. Your guys' knowledge is invaluable for so many. Jackson knows she spent the winter in Logan. That's where she was living. So you guys had the
Horrible.
the crazy winter.
But at least I had Michigan to like reference from. Like we had so much lake effect snow there that it was like, okay, like it's fine, but it just never stopped here.
Yeah.
The good thing about snow here is that it's a lot lighter than in Michigan. In Michigan, it's like wet, heavy, and brown.
Yeah.
And here it's like light and fluffy, so that part was cool.
Yeah. Well, that's incredible that you guys both have a passion for it where there is such a need, especially, I mean, everywhere, and with it being the disease causing the second highest mortality rate. Or has it surpassed? Megan, you spoke on that recently.
So it used to be the number one, like the highest mortality for eating disorders. Then the opiate epidemic happened, and that has surpassed it.
Yeah.
But it's still super significant. It's like one person every 52 minutes dies from an eating disorder. So,
I want to speak on the look of eating disorders. Is there a certain look, or I think people sometimes assume that, someone with anorexia would be really thin, or someone with bulimia. What does it look like, and who is the most affected by eating disorders regarding race, gender, that kind of stuff?
So I think the most like popular or like well-known eating disorder is anorexia nervosa. And when you see it so like publicized and like you see this like most severe form of it, so that'd be the people that are severely malnourished with really low BMIs that are very sick. And so that's what gets put out there, and that's what's like put out into social media, like to the bone. It's like was a chance for like eating disorders to be like broadcast out there, and it was just this most severe like stereotypical eating disorder there is. I think it's something like less than 6% of all eating disorders are classified medically as underweight. So it's such a small percentage of what is actually happening out there. And I don't know about you, but like I feel like that's such a barrier to seeking treatment because it's so competitive in nature. But then also you see that I'm not like as sick as these people, so my eating disorder isn't that bad. Like I don't need any help.
Right, the idea of like I'm not sick enough to get help. But yeah, I think media portrayal is like, malnourished, thin, frail, white women, when in reality, like, that's not the case because less than 6% are medically underweight. And I think that they're notoriously underreported in males because of that stigma.
Definitely.
Also, I think we have to look at the healthcare system as a whole, and like the biases the healthcare system has towards people in diverse bodies or in larger bodies,
Yes.
because if you have a larger body, then you need to be eating less and exercising more. And so it really like demonizes that shape and that I'm doing what I'm supposed to be doing, or just has a lot of like conflict, I feel like, too.
And on that point, I know that there are a lot of therapists and clinicians that use the health at every size philosophy. Can you speak a little about that, Hannah?
Yeah, I kind of see it, and feel free to correct me if you see it differently, but I kind of see it as like health at every size is the belief that anybody at any size can be healthy. Not saying that everyone at every size is healthy, right? Like I know plenty of people in larger bodies that are very healthy and plenty of people in smaller, like healthy looking bodies that are very unhealthy.
Yes.
But it really is the belief that like weight is not a determinant of health. So, and I like practice by that philosophy as well.
I love that. I know that, like you said, anorexia is, and bulimia, you hear about those a lot. I know people have talked about binge eating disorder more and more. But what are some of the other ones that come in that you guys see and that people should watch for?
You have a favorite you want to start with?
I think that a ton of people don't know about ARFID, or avoidant restrictive food intake disorder, which can be like characterized by malnourishment, like deficiencies in nutrition. But oftentimes it's not body image related, and it's more like sensory related, like texture wise with food, or a fear of like vomiting and that kind of thing. And so I think like really keeping an eye on like sensories, if like, your kid or friend or whomever is like, oh, I don't eat anything that is like this texture or this taste, keeping an eye on those. And then, yeah, just like discussing the fears, like around vomiting and that kind of thing too.
And then it's, yeah. But
You could say it now.
yeah, so I'm frozen. No,
I wanna
this is
hear-
happening a lot with Tom. Like GT saw this in the last interview.
I want to hear more about rumination disorder. You don't hear about that a lot. You guys probably do. But what should people look for, loved ones that might see this in someone, and when should they reach out for help?
Rumination can be tricky to spot because a lot of it, unless you're, rumination syndromes when you do have an intake of food and then it comes back up. Either the people chew it and swallow it back out, chew it, spit it out. It can be like a real like comfort measure a lot to some patients. And unless you're like trained on what to look out for, it can be hard for family members to spot it in that way. But it can be super damaging to people's health. You have what connects to your like esophagus and your stomach is like your pyloric sphincter. And when you have a lot of rumination or you having the food come up, this happens with purgers too, but with rumination as well, that valve right there becomes really floppy and loose. And so it takes a long time to get that tone back. So a lot of times it happens what they think is like involuntarily, but normally when you dig back down, it's due to like stress and foods and certain things like that. But it's really hard to kind of treat that because it takes a while to get that tone back in that sphincter in order to help control those kind of symptoms.
That would be hard to spot.
Yeah, one of the best ways, so there's not a lot of ways to treat it. One thing is like diaphragmatic breathing. So that's where it's like mindful breathing. It kind of like vinyasa if you ever do yoga, and where you take a deep breath in and your belly blows out like a balloon. And then when you breathe out, it comes back in. That will actually tone and tighten that sphincter. And so I would just have my patients do it. for 10 minutes prior to and after each eating opportunity to try to get that tone back up to prevent some reflux and to try to control the symptoms. It takes a long time, but
to get that
that tone
feeling
back.
back in the tone.
Yeah. But you can always refer out to like physical therapy. There are specialists that can help with that a lot.
Okay. One thing I wanted to ask was, there's not a lot of treatment, and it can be scary or intimidating to treat, these disorders, just as we talked about with the rate of death so high. So any advice on those that are treating or, are interested in treating these? What can kind of break down those barriers of the fear that it's super scary and that, we won't know enough to help? Does that make sense?
I think like having not necessarily like a supervisor even, but like a mentor already in the field can be really helpful. When I've dealt with like the mortality of clients, I went to a supervisor and was like, I don't know how to deal with this.
Yes.
And so she really helped a lot. And now I feel like much more better equipped to handle that specifically. Not that I want it to happen, but I think having support in the field can be really helpful.
Yeah.
Also, like not being scared to refer up to a higher level of care, like knowing what you can safely do at your place. I struggle with that a lot in residential, like when DB clients coming in and like not feeling safe taking care of them even at a residential point of view, but feeling the pressure like take on because like the parents and the family and everybody else is struggling. But even in the outpatient, like it's okay. Like patients may be sicker than you're ready to take care of. And so it's always okay to refer out. There's so many levels of treatment. And just it doesn't mean that you're not good as a provider, you're not well equipped, or not well trained enough. I think it speaks more to your knowledge of it to know when it's safe for you to treat and when you should. It's out of your scope.
Like, know your limits.
Yeah. So to speak on that, when do you guys refer out? At what point do you feel, I know it varies with patients. So what are some things that you guys look for to say, okay, this needs a higher level of care. It needs the residential or intensive outpatient, that kind of stuff.
Well, I'm still new to outpatient, so I'm
Yes.
still learning. So I can't speak on like what I do because I haven't had that experience like come up yet. But for medical, it's pretty strict APA guidelines for criteria. There's certain numbers that you can hit. So those can be helpful. But then again, that only gets you so much in terms of like treatment. But like if you look for making like you're checking like vital signs like heart rates, you're tracking weights, lab work, if anything becomes like abnormal and the patient's motivation isn't high enough to do it outpatient, meaning that they won't comply to the meal plan, they won't comply to the exercising structure, stuff like that. I feel like that's when you kind of have to start thinking about a higher level where there's more monitoring and take some of that stress and control out of like the client's hands and puts it into somebody else.
Yeah, absolutely. Yeah, like definitely weight motivation. I actually often refer to like the APA guidelines for eating disorder treatment. I like have it as a saved tab on my computer so I can go through and review. But one thing that like even now kind of increases my like fear with clients sometimes and for level of care is like the amount of purging that someone might be engaging in, because purging can just be so dangerous. So
this patients I was most scared to admit at like residential level were the ones that were purging outpatient because you really have no control over what they're gonna do. Where anorexic is the one that they're so sick because they're so skinny. Like purging is so detrimental because you're losing all those electrolytes and the electrolytes you need for your heart to function so you don't go into lethal arrhythmias. It's really like they can go downhill so quick and it's really scary.
Wow. Can you speak a little bit, Megan, on some of the other complications with the purging?
Yeah. So other complications, like the one that scares me the most is the heart stuff. So you can have changes in like the electrical activity of your heart. Can prolong the QTC interval as a part of it. And that what places you at a high risk for arrhythmias, and the QTC can get prolonged due to imbalances of your electrolytes. So magnesium and potassium are big ones. If those are low, which happens a lot with vomiting or with laxative use, that can really lead to it being scary out there. Other things that can happen with purging, one that I didn't realize so much until I was actually treating them, was all the like damage that can happen to like your oral pharyngeal. So like all of the dental issues that arise. I've seen like for patients with like 7 cavities, had to get root canals, they had to get all this stuff done. And they had like a lack of insight to it. And even I had a lack of insight to it because you wouldn't think about like teeth, but.
And why do the teeth get damaged?
So when you're purging or when you're throwing up, when the vomit comes up into your mouth, it's highly acidic. The acid erodes the enamel in your teeth over and over again. And when patients are purging multiple times a day, that's just multiple times a day that you're just eroding the teeth that aren't built for that. And so it really can do some damage over time. And pretty quickly, honestly.
Wow. And I bet, they're not thinking about that, and it can damage the lining of the esophagus as well. And that's not on their mind. So good to be aware of.
Yeah, it can have you can develop GERD earlier and the longer, so gastroesophageal reflux disease. And the longer that you have GERDs for, it increases your chance for Barrett's esophagus, which is a precancerous like disease. And so it can have long-term effects that people normally wouldn't think about.
What's the best way in treatment? It takes a lot of people on the team, a therapist like Hannah, a medical provider that can do the physical health, and then there's also co-occurring psychiatric disorders, and then a dietitian. So how do you get all those pieces lined up? How do you find those people, first of all? And we'll start there. How do you line all that treatment up?
I have specifically with dietitians, I have a list of dietitians that are eating disorder trained that I often refer people to. And I think there are like 6 on there. They go from like here in Kaysville down to South Salt Lake. And so I'll give that list to my clients or my clients' parents if it's a younger client. And I just kind of stress the importance of that. The fact that like, yes, I can support you like in renourishing yourself, but I can't like speak to the scientific part of nourishment. So.
And do you find that they're able to get in, or how's the wait?
Yeah, sometimes it's like a couple weeks. I have a few on the list that I refer to more than others just because it is easier for people to get in. Like one of them has like, I think 6 dietitians at their practice, and they're all like health at every size, all foods fit. So I feel like a couple weeks is typically like how long it takes.
Yeah. And then how about on your end, communicating with a medical provider, or what does that look like?
Sometimes it can be tricky.
Yeah.
But I have like some that I communicate with via email, some I communicate with via phone, and most of my clients right now, we do it on like an as needed basis. I've had clients with like higher severity that we've had like weekly check-ins every week with each other. But right now I do it like as needed.
That's great. I love that. Communicating with the whole team, keeping everyone involved. Why is that important to communicate with the team? What can happen, if you're not?
I don't know about you, but one of the biggest ones that I've seen is all of like the staff splitting. So like, well, my dietitian told me that like my meal plan's fine, my weight's fine, my therapist said my eating disorder isn't that big of a deal. And then conversely going back to like the other, like there's just so many like gaps with eating disorder patients. And so you have to trust, if you're not communicating with the providers themselves, you have to take what's coming from the client.
Yeah.
Right. Yeah. Like I think just like the complexity of them, right? Like, you know so much that I don't. And B, like, we might have a shared client and she tells you one thing and then me another. And so just making sure that everyone's on the same page, I think is really important.
Yeah.
Something I've been found to be helpful when I communicate with other team members is like reporting like lab values, because I like to use like labs don't lie. it's like a good way to kind of hold the patient accountable, like for increased amylase if they're purging. Like that's usually solely an indicator of purging unless they're having pancreatitis, which usually isn't the case. So it's good to kind of communicate that when trying to get how their behaviors are right now, if they're under control or not, and then passing that information along to like the therapist or the nutritionist to talk about in their next meetings too, just so everyone can kind of be united front to tackle it.
Yeah. And I mean, the therapist sees the patient more often than we do as providers. And so I like that they can help keep, checking in on how things are going. And if you guys have communicated, Hannah would know what to check in on, right? Because
Right.
you see them much more, and yeah.
And they're so much more open with you guys than they are with their medical provider. Like they tell you guys everything.
Yeah.
And like as much as like I can try as a provider, like we don't have that. I don't have your training of being so like knowing those like therapy techniques to like build that rapport in that manner. So I feel like all the info always comes from the therapist, and I'm like, all right, cool. I'll bring that up.
I'm happy to pass it along
Yeah.
anytime.
Yeah, that's very helpful to all be on the same page and give the client the best care, and for young ones, give the parents, that peace of mind that you're all communicating. So how do you get buy-in from the patient? Because these are very secretive in nature, eating disorders, and they can be embarrassing and they can be an identity. So how do you get buy-in for them to engage in treatment?
Well,
I mean, it's hard, but
It is hard.
what are some ideas? What are some ideas?
something that I found to be helpful. Again, I'm come from a different like domain than you do, but I have like the benefit of using objective information. So the data that I collect, like whether it be vital signs or lab work, or an EKG, those are objective information. And so sometimes when you present those to the client, it makes it difficult for them. It kind of brings them out of like their head and kind of into what's going out in front of
The
them.
reality of what's
Yeah.
happening.
Yeah, it doesn't always the case. Sometimes it can be argumentative, and well, that can't be it. Like I'm not doing that still, but that's one thing that I found to utilize a little bit more.
Yeah. I think that from like research I've done and like readings I've done, I love to throw statistics at people and like
Yeah.
numbers. I think that can be really helpful. Like when I have someone come in and they're eating, a really low calorie amount, I like to, say like 1,200 calories is what a toddler needs in a day, not, a full grown person or like a growing teenager and that kind of thing. But I think a big piece of like what I do is that building rapport. Like I try to really build a relationship with them, and I see mostly teenagers. So
Okay.
like trying to really build that relationship and that trust, and then, pointing out like, what do you think it would be like if you didn't eat food? Like not eat food, sorry. What do you think it would be like if you didn't think about food all day? Right? Because oftentimes they're thinking about food, not necessarily eating it, but like, how am I going to avoid eating it at the next time? Or, if I eat this, like, what's my opportunity to purge afterwards? All that kind of thing. So just pointing out like, do you know how much more brain space you'd have if you didn't
Right.
think of food all day long? So
That's a lot of time and
Those-
energy.
Yeah, and those scary statistics are like, I think they're really impactful too. And like when I pull out the information that I have and like warn them of what could be in the future, it doesn't always hit because sometimes there's an aspect of like, oh, I'm not that sick, like whatever, it's not going to happen to me. But a few times you really can see like the look set in on like the patient's face and kind of see it like hit a little bit. It doesn't mean that actions are going to occur that day, the next week or whatever, but by planting those things, I think over time, it can kind of help. And it also helps a little bit with parents too.
yeah.
I think it can help parents kind of focus and hone in and like help their child the best way they can in terms of like, well, for like doctor's appointments or like things like that, and making sure that they hold them accountable to like the recommendations their therapist or nutritionist, dietitian has. So
Yeah, I mean, like we said before, it's a lot of time. It's a lot of appointments. A thing that I have heard quite often is this from therapists. They have, and other providers, they say, the provider will say this child needs a more intensive level of care, and they'll say, I need to have the parents buy in. I've heard that a lot where they say they're okay, they'll be fine. So I love hearing that you can give some statistics and kind of the reality of where it could be headed.
Right. Yeah. And if parents are like, oh, well, they say they're fine, like they don't want to come as often, we want to decrease appointments. This might be like a really big thing, but I say if your child had cancer, you wouldn't let them miss chemo. Let's not let them miss therapy. So
that gives me chills because it's true. It might not seem as severe, but it is, or even more so severe than some of those medical diagnoses.
I'm going to steal that line.
Please do.
It's good. So I know that family therapy is a huge part. Can you guys speak to that a little bit? It's another thing that takes time. It can be hard to manage schedules, get those appointments set up. But why is family therapy so important in this case, in treating eating disorders?
Oh my God. You're the one that does family therapy.
Do you do the family therapy piece, Hannah?
I do. I bring in, sometimes it's not not typically the entire family.
Yes.
And it's definitely not every session. But I'll bring in like a parent or both parents. But I think like part of the reason it's so important is like, sometimes people lie to their parents. Like, parents might not know the severity of what's going on or everything that, their child is doing. B, I think that working towards recovery can be very isolating, and the more support that you can have, the better your chances are. And then from like a nutritional standpoint, I have certain clients that their parents plate their food right now. And we work with a dietitian to get them to the point where okay, when can you start plating your own food again?
Mm-hmm.
But I think it's just so dynamic. And again, I'm a broken record, but complex, that any support they can get is better.
Yeah, definitely. And I think, like you said, how isolating to do it on your own helps keep you accountable. And I love that you are teaching the family, how to help in this situation. I know a lot of people don't know what to do. Yeah. So it can be hard for everyone. So I love that you do that piece.
How does family-based treatment work? How does that how effective is that? Or do you see a lot of pushback or?
And can you explain what family-based treatment is? Because that, or generally,
or the plating, the plating. Because when I've heard of it, it's my mom was the food police, and then
does that cause
a lot of struggle?
That's fair.
So I'm just interested in how you actually see it.
Do you have clients coming back complaining about the plating?
Oh, for sure. Yeah.
And
my
how
mom
do you
puts
work?
way too much on my plate. My dietitian wants me to eat way too many carbs.
Yes.
All of that kind of stuff. I think that kind of again, almost with, when you refer a client to a higher level of care, some of that control is taken away, so they don't have to worry about all the ins and outs. Usually if I have a client that's stepping down from residential, their parent will plate their food for a few weeks afterwards.
Okay.
And how I think that statistically family-based therapy is one of the most proven treatments for teens struggling with anorexia and bulimia. But I think just increasing parents' awareness is just a huge part of it.
Mm-hmm.
And I forgot the other question you asked.
That's okay. I asked
So
a
did we
lot
all?
at the same time.
We're I don't remember either.
I forgot.
But I think if there is not family therapy going on, how will the parents know how to help? There's so much change and involvement that needs to happen.
Right.
And for them to invest in getting to all these appointments, it's a lot.
It is a lot. It's a lot for sure.
So I like that.
I think it's important, especially whereas I work with a lot of teenagers, if I'm talking solely with the teenager, that's not gonna, change the home environment, right? Typically there's a dynamic happening there that needs to be addressed.
Yes. One thing, switching gears a little bit that I know is important is kind of this I think is helpful for families all over just because of the diet culture in our society and every magazine out there, the pictures and the drive for thinness and for healthy and all the different diet fads that are out there. So I want to kind of have you guys speak on neutral language around food. I think that is huge. One reason why it's important to me is I have a daughter that has type 1 diabetes. She's 13 now. She's had it for 4 years, but everyone will say, oh, she can't eat this and this because that's bad for her blood sugar. Well, they don't know why. They just know it's bad for diabetes, quote unquote bad. And so I did a lot of reading on that because I know eating disorders are very prevalent with those with type 1 diabetes, diabulimia, I believe it's called. And so, we had to incorporate talking about food in a neutral way, like food is fuel. But can you guys kind of touch on the importance of that? Because I think that's helpful, not just for people, families with an eating disorder in their world, but just in general as a society.
Yeah.
What a broad topic.
I know.
Yeah, but I think that I was lucky enough to work with some really good like registered dietitians, and we collaborated a lot at my previous like treatment center that I used to work at. And something that she found like when she was meeting with clients is that kind of like going through and like letting them know what each food is kind of good for. Like the patients that really like to like exercise and go for a run, they want to have that part of their life back.
Mm-hmm.
Letting them know that carbohydrates are a quick source for you. It's a source for your body that needs the energy right now so you can have and like exercise in these like healthy manners and give your body the fuel. But there is just so much in the culture of like you need to cut out like meat. Like, oh, you have acne, you need to cut out your dairy, sugar, processed foods. Like that's not healthy either. Like that's going to cause a lot more issues. And then the solution is like, oh, I'll just take a vitamin, or I'll take like this like powder, like this green powder
supplement,
and like that'll fix everything. And it's your nutrition comes from food, and it comes from what's available out there that's meant to be eaten. And the more you process it and break it down and turn it into these like capsules and supplements and everything else, the less benefit, and your body doesn't know exactly how to use it or process it. So you don't get the same benefit.
Yeah, no, definitely. I also too try to like steer clear of good and bad foods or clean and junk food. Because I think using the term clean implies that other things are dirty and food's not dirty, right? Like we all need it. So doing that, and I'll even talk to parents about like, even if you're not saying it like to your child, they're still hearing you say it, right? Like at the kitchen counter, like, oh, I've been so bad today, I need to do better tomorrow.
Yes.
Your food has no moral value.
I love all of that because it really has become that to a lot of people, where it's a moral thing and it's good and bad. So yeah, and I like how you touched on food. We always say food is fuel. How can this fuel my body? And that seems to take away some of that moral piece of it.
Right. It's like these are already such shame-based issues and diagnoses that people are struggling with. Like we don't need to add to that by labeling our food.
Exactly. Yeah, I love that. I know that there's not a huge place for medication, and it can be tricky with eating disorders, but what are some of the things that can be helpful? I wish I could just show the slide that you presented on, Megan, but explain a few of the disorders and just, what do those medications help with?
Yeah, so I guess we can just go like categorically. So for anorexia, the primary treatment is nutritional rehabilitation and therapy. If that fails, that's when like any sort of psychopharmacology can start to be implemented, but there's only so much it can do, right? some ways that we can implement it, like for our patients and for our like loved ones, is if we give them something to help reduce like mealtime anxiety. So help reduce anxiety prior to meals. Something like that we use is something called like hydroxyzine or Visceral. You can give it prior to meals to kind of help calm them down. And it's important with all any of these medications we talk about is that they're not used for like long-term treatment. They're used for time to get the therapy and everything that they're learning from all their different domains to like settle in, for them to realize it, to help give you time to like for the motivational buy-in period. And other things that are used are like antidepressants are used a lot, and then olanzapine is used a lot in the outpatient setting. It's a antipsychotic, which that in of itself kind of scares a lot of people.
And what's one of the side effects?
So the big side effect, because anytime you give a patient a medication, they're going to Google what like the side effects are. Like, is this going to make me gain weight? Olanzapine is one of the side effects that they will see is that it makes you gain weight. Something I use, and so that causes a lot of struggle when you're trying to prescribe medication for a patient that doesn't.
For those on olanzapine, keep taking it.
Yeah.
Side note.
You need it. Everybody needs it.
Consult your doctor if you want to come off of it. It is a good medication, but sorry to interrupt.
No, you're good. That's a good thing to interrupt for. But yeah, so when I have these discussions with my patients, I kind of bring up a couple of points. One of the points is that when they do these studies for these medications, they test it at much higher doses. They test it at 5 milligrams, 10 milligrams. I'm only giving you a portion of that. It's a very smaller portion. So it's not, according to the statistics, it's not going to give you as much weight gain as what you're seeing online for the average weight gain when you're looking at these studies these drug companies do. They don't like to believe that. Sometimes it does work, but it's hit or miss. Also, another way to look at it is they use it as a temporary bridge to help you feel better. You be honest with them, weight gain can be a side effect. And we've given you chances to kind of help work this with your therapist, with your dietitian, to gain weight on your own. We're struggling right now. This can be kind of a way to help get you there and get you there faster. Sometimes, again, doesn't always work for any of that.
Right.
But another big one is just giving an antidepressant. And then a lot of the times we hear, like, why isn't the antidepressant working?
And why isn't it? I love that.
Yeah. So what builds up neurotransmitters, that's the serotonin, the norepinephrine, the stuff that the happy chemicals that your body makes, it comes from amino acids. 2 amino acids, tyrosine and tryptophan, those they're called what's essential amino acids, meaning your body doesn't make them, you have to get them from outside sources. So that's stuff like poultry, beef, salmon, dairy. Those are red meats and dairy, stuff that typically get excluded when we're doing a restrictive behaviors or any sort of like active behaviors. That could even be purging as well, because your body's not getting those nutrients because it's getting released before they get absorbed. So if you're not getting that intake, your body, they can't make those neurotransmitters, because the amino acids are only for neurotransmitters. They're for other things, anything that needs protein to make it up in your body. So that could be muscles, that could be thyroid function, that could be GI issues. So your body gets only a limited amount. They have to decide what's most important. And so they can go to other things. So you're not necessarily getting those neurotransmitters into your system, so your medications can't work as well at the receptor point. So
the SSRIs might not even be effective. And is there a supplement to replace not getting tryptophan, those benefits?
Again, the best way to get those things, the way that your body can absorb it the best way, is through those foods. Yeah, because you want to get it from those animal proteins is the best way to get those. Do you want me to keep going doing the other ones? Or you stop anorexia? I'm going to say one thing about bulimia.
Yes.
So bulimia, a hard thing with any medication, there's any purging going at all. So it could be anorexia nervosa, like binge purge subtype. If you're any sort of purging, you're not getting the full medications benefit because it's getting released too early. So one thing I think this is important, where you collaborate with your dietitian your dietitian and your therapist, is trying to identify when these behaviors are most likely occurring. Not usually, but a lot of the times they occur like during the day. And so giving the medication at nighttime, that gives the best chance for your body to absorb that medication. Prozac's a really good one. It's helped a lot with binging and purging behaviors.
That's great. And that's a good reason, yeah, why the collaboration piece is so important, because then they might tell Hannah, when the behaviors are happening, they might not share all of that with you, Megan, and then you can adjust dosing or the timing, I guess, of the dosing of the medication.
Yeah, because
to
I'm sure
give
that
them.
comes up in therapy. Like, I'm taking this medicine, it's not doing anything for me. I'm not
Mhm.
feeling any better.
Yeah.
And that could kind of be a way to bridge that.
Yeah. And I love that
conversation.
Hannah could then talk with you and you guys could figure out
Mhm.
what needs to happen.
Yeah.
One more I just wanted to touch on was binge eating disorder. And are there any medications to help that? I know, that can be a quite embarrassing disorder. But are there medications to help that one?
2 medications I like using.
Mhm.
Prozac, again, it's shown to help with those behaviors. Bupropion can help as well, or Wellbutrin. Those work. They're also can be helpful as far as weight management goes, because there's not a lot of weight gain associated with those 2 medications. That can be helpful. One of the FDA-approved medications for binge eating disorders is Vyvanse.
And what's Vyvanse?
Vyvanse is a stimulant.
Used to treat ADHD.
Yeah. And they found as a side effects when they were treating the ADHD is that it causes appetite suppression. And so I've had patients where I've seen that originally had like bulimia or they had binge eating disorder. The doctor gave them Vyvanse, and now they've developed restrictive tendencies as well. So now we're dealing not only with like the binging and the purging, but also the restricting aspect to it. And if you had a patient that wasn't overweight and was on Vyvanse and they were losing weight, you would stop the medication. So why is that allowed in a different body size?
Mm-hmm. Yeah, that's good insight. I got a question from someone. I'll just read it and you guys can be thinking about it. It's someone that has a older, just barely adult daughter. She's had anorexia for several years. She's been to 2 residential treatment centers and is doing much better. But now, even though her mindset is better, she's eating about 2,600 calories a day and exercising 6 days a week, running 20 miles a week, and also doing strength training on top of that. She has been working with a dietitian and a doctor and a therapist for about 2 years to keep her on track, but recently has been on a path where she's lost 20 pounds of weight, and the dietitian said she's good to go and doesn't need to see her anymore. So this concerned parent was kind of saying, what is recovery? What does that look like when someone is quote unquote recovered or better? What's the long term? Just so people kind of know what that can look like. Again, I know it varies, but what do you recommend?
I think there's a couple components to it. I think that there's one thing that's important is that you want to look at what a successful like treatment is, or like the goal, like the treatment goals, and that's different than what recovery is. Treatment goals are getting you back to your body's healthy weight, the body that you're like your pre-eating disorder like body type is getting you back to there. And then cessation of behaviors, getting rid of those behaviors that are harmful. So that's the treatment outline. Because you completed or because you've achieved your treatment goals, is, in my opinion, doesn't mean you're recovered. I don't know.
I agree. No, I agree.
Like a treatment goal of gain 15 pounds. You've done that, but there's so much more.
Right. It's like, I think that sometimes, especially in like the online eating disorder community, people talk about, well, I'm weight restored, I'm recovered physically, but I'm not recovered mentally.
Yeah. So how do you tackle that? What do you have?
That's all you
do?
Because I did that thing, and now they have their healthy weight, they're good to go. Like I just
And then
check to make sure they check in
therapist.
and like keep following up. So like a lot of it is you.
What are some things that you recommend that how often do you continue to see them once the goals on the physical side have been met, I guess?
Yeah, I think kind of like you said before too, like really paying attention to those compensatory disordered eating behaviors, right? Like if someone's like running to make up for what they ate, or you know what their food intake is at right now. And I personally look at, like, again, have your thoughts of food like all day long, have those decreased, and how are you feeling in your body right now, right? Like recovery is hard with weight restoration, and I think that can even bring about more body image issues. So then, like, okay, maybe
Yes.
we're not focusing on like your eating disorder behaviors, but we're focusing more on body image right now. And I still think that that's like a really big component.
For sure. Very big. And that touches one of my favorite and touchy subjects, is the social media aspect. I mean, do you touch on that when they're in? Do you ask about that, or what are recommendations for that for those that are having trouble with body image, or even heading or deep in an eating disorder? What can people do regarding technology use, specifically social media?
I encourage all of my clients, whether they have an eating disorder or
Yes.
not, if you're following someone on Instagram, Facebook, TikTok, whatever, that makes you feel bad about yourself, unfollow them.
That gives me chills because it's just such a problem.
It is. Yeah. So I'll like sit in session and have people unfollow people sometimes.
Okay.
When I give therapy homework, I'm like, all right, I want you to unfollow 5 people this week. So
That's awesome.
that's what I do.
How do they
Yeah.
respond to that? What's the reaction?
Some people are totally for it and they're like, okay, yeah, that makes sense. I would say more often with like the younger generation, that made me sound really old. They they're like, I don't want to unfollow people. Like,
It's a
you know,
big
like
deal.
these are my friends, or any of that kind of thing. So, but then we talk about, you know, you can still be friends with them, or we'll even talk about like muting someone's account so they're not popping up as often.
That's a
And
great
like,
idea.
then if they look at it, you're still friends, but you're not seeing, you know, all of these pictures they're posting.
Yeah. And do you think it's just teens that have trouble with social media and getting body image?
I mean, I'm not a teenager, and it's prevalent, and it affects everybody.
Oh, yeah.
around
It
you.
affects-
Yeah.
Yeah, I
every-
think regardless of age.
So you have to be careful. I think a lot of people think it's teens, you know, that's where the issue is, teen, young adults, but it just is a problem because it's everyone's perfect little pictures.
Yeah, I know I'm in the next like month or so, I'm starting a body image group for teens, and I was like, oh, I wish I could do it for adults too, which I know I can.
Right.
But the curriculum I'm doing is specifically designed for
Neat.
teens.
That's
So,
awesome.
but I'm like, I think this could apply to anyone at any age.
Yeah. So, kind of back to that question on recovery, just I like that. Yes, you meet the goals, but keep checking in. I mean, do people graduate from treatment? When is it time for them to, or do you just spread out appointments and check-ins?
Yeah. So when I hear graduate from treatment, I think back to residential, and like
Right.
so rare do people actually graduate from those programs, because that you want to like treat them to outcomes so that they can like go, and that was my, I feel like I should credit my previous facility, that was their motto, like treat to outcomes so that they can be successful in the next
Neat.
outpatient. But before they even go, we have to make sure that they're set up with a psychiatrist, a nutritionist, a therapist. I need to say dietitian, not nutritionist, so dietitian, therapist, and there's primary care provider. They have to have all those appointments within a week, and that's people who are really at a great place in their recovery at that
Okay.
point. But I think check-ins, while they may decrease in frequency, I think it's important that they still have that piece to get held accountable,
Yeah.
because any stressors happen every day of your life, and eating disorders can be used as a way to control certain aspects of your life. And if you lose any sort of control, it takes a long time to replace those behaviors where you don't go back to it.
Right, because our brain goes back to what we know.
Yeah.
And so if it knows like, oh, things are bad again, I'm
Let's
going to start restricting again, then like it's just such a slippery slope.
Yeah. So just like primary care providers, you know, they do their well check every year, you know, a physical. Do you think something like that is a good idea? I mean, maybe even 6 months, you know, for people that have been through treatment and doing well, just to check in?
I think it's important to see them at what the patient needs.
Yep.
And it can be, a lot of times it's more
More.
frequently than every
Yeah.
single year.
Yeah.
Especially in the initial process of either discovery or stepping down from level of care. The more freedom and the more room that patient has, I think it's more important to, because that's when there may be like the higher chance of like slipping and falling back into old behaviors. And so I think it's really important to be held accountable at a frequent rate, especially in the beginning portions.
Definitely.
And it's always okay, like, it's not like a sense of failure if you were seeing like your dietitian, like you went from seeing them weekly to biweekly to monthly. And it's okay to go the other direction and go back, increase in frequency. That's even like better, because that means you're recognizing what's wrong and you can intercept that behavior quicker.
Absolutely. And I think that like talks to, how important it is to have a treatment team too that can maybe recognize your blind spots, right? Like you feel like things are going really well, and then I come in and I'm like, hey, I think you need to talk to your dietitian about going back up to like biweekly instead of monthly, just because of like A, B, and C that I've seen. So
I love that. Yeah. And just like in our lives, things ebb and flow, stress ebbs and flows. So, yeah, being okay with coming a little more often, or it might kind of wean down to less often. I think that's important. How do you, because you work with a lot of teens, Hannah, and so what does the first appointment look like? If they come with a parent, most likely they do. Does the parent come in for the whole first session? How does that look like for someone wondering what the first appointment entails?
yeah, I think it definitely depends on the therapist. Like
Okay.
I think there are therapists that keep the parent in the entire time. I kick the parent out after the first 10 or 15 minutes and make them wait in the waiting area. And then I talk to the teen one-on-one, because I've found in my experience that they're just maybe a little more likely to open up with me if, mom or dad isn't sitting like right here. And yeah, so then I go through like questions about daily life and regular things, and then I ask a lot of specific questions about eating, relationship with food, relationship with body, all of that kind of stuff.
That's great. And is that how every session goes? The parent will come in for some, or after that initial, is it mostly just the adolescent for the full time? Does
I
it
would say it
depend?
depends on the client.
Okay.
I've had some parents join the entire time, like definitely if we're doing like family-based treatment. I have some parents that we kind of reserve the last 10 minutes of session to check in. So I think it just depends on the client and the parent, and we make sure we come up with a dynamic that works for them.
Okay. And do either of you do telehealth for treating eating disorders?
As a medical provider, I feel like there's so much objective data I need to do in person to really evaluate what's going on. So I like to see my patients in person especially in the beginning portions of treatment, and usually pretty regularly, because I'm monitoring weights, I'm monitoring vital signs, like lab work, stuff like that could have been, it could be skewed in a different setting. So I feel like it's important to see them in person.
And then say they're getting better and say they live quite far. Is that an option later or no? Because I know you still need to get vital signs and things, but is that a possibility for anyone that might be really far, or what would you recommend?
So can get a little tricky.
Yeah.
Because you want to keep monitoring those objective data points so that if things were to slip or things are going backwards, you have like a when it happens, so you can determine like appropriate level of care moving forward. And then I think that also plays into what their team looks like outside of like the provider, like where I'm specializing in the eating disorders and I'm like focusing on the eating disorders. If they have another primary care physician, like a pediatrician they see yearly, that it's closer to them and I can communicate with them openly about the patient, then I think later on down the road, we can collaborate in that manner where we can address some things telehealth. But that's hard to tell because I'm still trying to feel it out and stuff like that. But
how about you, Hannah? Are they all in person?
I highly prefer and recommend in person.
Yeah.
I have a couple that, like, oh, my car broke down, I can't make it.
So emergency type.
Yeah. But I really, just because too, as a therapist, like I pay attention to body language so much. I think it's so important. And if we're virtual, I'm only seeing, here to here. And I'm not saying that you're like jiggling your leg or fidgeting with your hands or any of that kind of thing. So I much prefer in person.
Yeah.
But I'm willing to like negotiate with people.
That makes sense. Let's see. I don't think I have anything else. Is there anything else you guys feels important for people to know? I know that's very vague, but or what are kind of the top, do you get top questions that are asked or concerns or, well, I guess one thing I do want to ask Hannah, when they come in for therapy, or I guess for either of you, what are warning signs that families can look for? I know they're often posted, like a list, but I think hearing what to look for can be helpful when people are like, when do we come in?
I think like weight fluctuation, suddenly dressing in like tons of layers or baggier clothes.
Is that for anorexia, binge eating, or
I would say across the board.
Across the board.
And then, like restriction with foods or, calories or specific foods. I also think like obsessive exercising, if I can't get to the gym today, that means like the day is crap. I'm not having a good day. And I would say like a lot of time in the bathroom, especially after meals. I think that can be a big warning sign to pay attention to.
And what about change in social, climate?
Yeah, I think isolation can be a warning sign of a lot of things, but I do think it can be a warning sign of eating disorders as well.
You saying someone spending a lot of time in the bathroom. So say someone is and you're concerned, it's after meal times or during meal times and you think, they might be in there doing compensatory behavior. So what do you recommend for someone to do? I get that question a lot from just friends or something. They've noticed something, because that can be awkward and maybe you don't do this as a therapist, like recommend. What can they say? Does that make sense?
Yeah, I honestly think like just having an open and honest conversation is going to be best. Like, yes, it might backfire in the moment, but I think having that conversation is really important.
Do you think that would help the person that might be struggling to be aware that there is a problem? They might.
Maybe. Yeah.
Okay. But just having an open.
Could send in the opposite direction of denial, right? Like,
true.
No, everything's fine.
True.
Yeah. But I think like just talking about it, like, hey, I've noticed that you've been spending a lot of time in the bathroom. Like, are you feeling okay? I'm going to be upfront. What are you doing in there?
Yeah.
That kind of thing.
Yeah.
So
I like that. So don't be scared to ask.
Yeah.
Even if it might backfire. I don't know. I like that, having a candid conversation.
That's good.
Anything else that you want people to know? Hannah is with Aspire Counseling, but under Gold Counseling. She's very full, very excellent. But you can call Aspire to reach her. And then Megan is with Aspire Medical, and she is filling up, but has immediate availability as of now. And so, yeah, you can just call Aspire Medical to reach out to her. Yeah.
Mm-hmm.
Get help if you need it.
Yes. Don't be afraid to reach out. We're welcoming and non-judgmental.
Yeah.
So
actually, that's a good point. A lot of people say, I'm embarrassed to go in. I'm embarrassed to say what I'm going through, what I'm dealing with. I don't want to be judged. So I love that Hannah said that, and Megan was readily agreeing that we've heard a lot of stuff. We have heard a lot of things, and we just want people to get help. That's why we're in this profession. Mm-hmm. It's so rewarding and fun to see people get better. And so I promise you won't shock anybody. So just make the call. I think making the call is the hardest part. Well, finding someone. Now, Hannah is full, but there's other resources. And so if you are looking for somewhere, call, and there's intake specialists that can help, because we know that this is a very underserved demographic of mental health treatment. So yeah, reach out.
By letting us help, it takes some of the burden off of you too. You can put it onto us and we can help you through it.
Yes,
Yeah,
that's
absolutely.
huge. Even parents, such a burden for the worry. And like Hannah said before, the mental space that all the thinking and counting and worrying takes up, that is just exhausting. So I like that you can pass it on over to us, well, to them. I also am very interested in eating disorders. I have not treated to the extent that these two have, but yeah, it's always been a passion just because I did know a lot of people that struggled. I had one myself. You can edit that, but yeah, but no one knew or where to go for help.
Yeah.
And parents don't know where to go, what to do. So it's just awareness. So if you don't need this help, but you know someone that does, spread the word about Megan and Hannah. So
Right. And
Thank-
if you start somewhere, we'll refer you to the other resources that you need.
exactly. And so really it's, yes, recognizing that you need help, but then making the call I know is hard. How are you going to pay for it? How are you going to find time for it? You'll find it, and your life can change for the better. So
The quicker you intervene, the higher chance of recovery. Rather than spending years and years going in and out of treatment centers, all
Yes.
this stuff, the quicker we get in, the quicker we can interrupt symptom behavior, which leads to better outcomes.
yeah.
Yep.
And once you get into treatment, there's a lot of resources, books and things like that. But as I was talking with Megan, and Hannah, tell us if you agree, there might be different resources. Well, there are different resources for, maybe the different disorders or different point in time where you are in treatment. So I don't know if we would want to speak here about that, but that can be part of your questions when you're in treatment. Would you recommend that?
Mm-hmm. Yeah.
Okay. So there's just so much help out there. So hopefully we can bring some awareness to this. So thank you both so much.
Thank you.
Yeah,
So
thank
fun to
you.
talk with you.